and some details on the Altogether trial. So I know that Professor Gibson gave a talk on ALL right at the beginning of this session and covered a lot of the basics of how children present with ALL, the kind of diagnostic tests we do. She did cover MRD. I will just do a little refresher on that here. And she talked about the evolution of the leukemia trials through to where we are today, and then has left kind of basically where we are today and forwards to me. So if any of you missed that, I would really recommend it. It's a really good introduction to ALL and the more kind of clinical aspects of it, as well as how we've run trials up till now. And this is essentially what she showed, that from the first report of a successful drug for causing temporary remissions in childhood leukemia, although not cures, back in 1948, leukemia has moved from a universally fatal disease to a disease that we hope that more than 90% of children will be long-term survivors from. So it's really been a massive medical and scientific success story, and really something that most other solid tumours can only kind of dream about, this stepwise progression right up to really, really high survival rates. And I think one of the interesting things about this is it's not because we've got lots and lots of new drugs. So there are a few new drugs, just particularly in the last kind of decade or so. But in fact, that improval up to 90% survival rates was done with some really very old-fashioned drugs, and the same drugs that we had at our disposal back in the 1950s and 1960s. So essentially the backbone of ALL therapy is the use of corticosteroids, vincristine from the periwinkle plant, asparaginase, relatively new, being introduced in the late 1960s, alkylating agents, which are related to the kind of mustard gas that was used in the First World War, so really very primitive agents, and nucleoside analogues. So we haven't achieved this cure because of miracle drugs. And the way we really have achieved this real improvement in cure rates has been through clinical trials and through the participation of families and patients in these trials. So we really have to thank all the previous patients with ALL for the kind of cure rates that we're seeing today. And it's been a massive, massive success in childhood leukemia. And I know that Professor Gibson took you through this, but I thought it was just kind of useful to go back to how we've made this progress. And we've basically made this progress by putting all children with leukemia into a clinical trial wherever possible. So clinical trials are not reserved for patients with refractory disease or end-stage disease, etc. Children with good risk disease that we hope to cure still go in a clinical trial. And the way that the clinical trials have kind of run up till now is that you've come along with your ALL, and then you've been randomized into either what is the current best treatment for ALL, which we might call standard treatment. And this is the treatment you would get if you weren't in the trial, if you like, so the standard best treatment for ALL. But you randomize that against something that you think that's new, and you're obviously hoping is better than your standard treatment. So you've got this stepwise, take what's the best, try something that might be better. And then you monitor the number who survive or relapse or die, etc. And then you take the best arm through to the next trial, and then you start again. So what you're offering parents, and one of the reasons why it's always been quite relatively easy to recruit to this trial, is you're offering them, you can have something that is you're going to get anyway, or you can have something that might be a bit better, but we're not sure about it. And most people obviously in that situation will take something, will get a 50-50 chance of having something that's a bit better and say, well, what's the worst that can happen? I'll just get the treatment that I would have had otherwise. So it's a relatively easy sell, or it has been up until recently. And you can see these are kind of the typical kind of results. So this is an old trial from the 1990s, one of the American trials. Here's the standard therapy with a cure rate of 50%, and here's the augmented therapy with a cure rate of nearly 70%. So obviously in this case, the children on the augmented therapy, that then became the standard therapy for the next trial. The next trial then tests that against something that might be even better, and you just get this stepwise improvements. More recently, it's become a little bit harder to sell to parents because you're now actually sometimes trying therapies that are less intensive than the standard arm, and therefore you might, you say to them, we think this is going to be less toxic, but we can't be certain it'll cure the leukemia to the same its extent. And that obviously is a much harder thing for parents to grapple with than something that's just stronger and presumably better, if you like. So I think I mentioned there about something getting the therapy's getting stronger. And so it's not so much that we've got new drugs, it's the ability to use them in intensive combinations, which has allowed us to cure leukemia. So that you really, in order to cure leukemia, you can't just hit it with one drug, you have to hit it with multiple drugs, and you have to keep hitting it so that any dormant cells and things are mopped up as they try and regrow the leukemia, if you like. And if we'd put a child from the 1950s through our current leukemia protocols, they wouldn't actually have been cured. They'd have almost certainly have died, because they'd have died of overwhelming sepsis. And actually, it's improvements in supportive care that have really allowed us to have these dose intensifications in leukemia. The fact that we can now treat bacterial sepsis with our broad spectrum antibiotics, we can treat fungal infections and all the kind of consequences of our ALL therapy. But I think this brings me on to a really important point, is that you can look at childhood leukemia and say, wow, haven't we done well? We're curing so many children with leukemia now, but actually we're doing it at great expense. And our current ALL therapy is extremely toxic. And these are, you don't have to really look at these figures, but these are the serious adverse event figures from the UCAL 2003 trial. I think this might be 2011 or 2003, can't remember. But you can see that these are the kind of children who had serious adverse events. So 13% of children having a serious adverse event due to infection, nearly 4% of children suffering a fungal infection, 7% of children having some kind of seizure, some kind of encephalopathy, 2% of children having hypersensitivity, that can be anaphylaxis. Not very many, but very serious complication of pancreatitis, which can lead to long-term dependence on insulin and pseudocyst formation, etc. 4% of children getting osteonecrosis, and that's even higher in older age ranges, and can lead to needing joint replacements. 2% of children getting thrombosis. So you can see overall, we really have significant levels of toxicity due to this treatment. And many of you will have seen this photo before, but I think a picture tells 1,000 words. These are sisters. You don't get any prizes for saying which one had leukemia treatment as a child, and you can see the impact of leukemia treatment potentially. But the thing that really drives home that impact is that these are actually identical twins. So you can see how much having childhood leukemia therapy can impact on your growth and your development and your health in general. And so we do cure childhood leukemia at the moment, and we cure it very successfully, but we kind of do it by blasting children with a kind of toxic combination previously of both radiotherapy and chemotherapy, but now just very intensive chemotherapy. And it certainly works, but we then have to think that the average child who's cured for ALL, the average age of ALL is about 3 to 4 years of age. So the average child who's cured of ALL, we're hoping is going to have 70, 80, maybe even 90 years of life ahead of them. And so we have to make sure that the way we treat these children doesn't do long-lasting damage to their normal body cells, which will then come back and haunt them later on, if you like, with late effects and ongoing health problems throughout their life. So when you look at how far we've come with childhood leukemia, and people do admittedly in jest, but kind of half seriously say, why should we put our money into childhood leukemia research? That's a solved problem. You cure 93% of children, move on and work on something else. But actually, we do still have an awful lot of challenges in childhood ALL. And the two predominant ones are, even if we cure 92, 93% of children, if your child is the 1 in 10 that's not cured, clearly we're not curing all of childhood ALL, and we need to develop novel approaches for children with resistant disease, because we've shown that pretty much we've reached the limits of our intensification of therapy. So we're not going to just cure more children by giving these same drugs in the same, just more intensive combinations. We actually need new drugs and new approaches, and we'll talk about a few of those. And the other thing is that we need to try and cure these children better. So we need to develop kinder and gentler treatments to cure childhood leukemia. So we want to maintain these excellent cure rates, but we don't want to cause so much damage along the way. And this is where the concept of risk-adapted therapy comes into, and I think Brenda also discussed this with you. So these are just the survival curves from successive leukemia trials. Obviously, now we will be up to 90% here. But if you look back at the UCAL trial back in 1980, we cured 64% of patients then. And since then, we've gone through, you count 10, 11, 12, ALL, sorry, not 12, ALL 97, 2003 and 2011. And essentially, we've intensified therapy and we've cured an extra 20% of children by intensifying this treatment. But we do know that there were 64% of children who would have been cured by this much less intensive treatment. And so actually those children haven't benefited from these new trials. They've actually been harmed by these trials in that we've cured them, but by giving them more treatment, and that's caused them side effects. And similarly, the kids that aren't cured, we haven't done them any favors either, and they're obviously still not getting appropriately treated. So the advances in the trials really have been for these children who weren't cured back in the 1970s or 80s and are cured now. And in fact, there is this large proportion of children who are actually overtreated, where we need to try and reduce their treatment. There are these children who are undertreated, who need the novel agents. And for all these children, we need to try and reduce toxicity of our cure. And this is just data from the Nordic group, just showing this risk of that now we've reached a point where we've brought down our death from relapse disease to such an extent that now for good risk patients, the risk of dying from your treatment, so from treatment-related mortality, is actually the same as the risk of dying from relapse disease. So this is 1992, this is 2000, and this is 2008, and you can see death from relapse has come right down as our treatments have got more intensive. But actually death from treatment has stayed the same at about 4%. So for children with good risk disease, your risk of dying from treatment and your risk of dying from disease is about the same, which just brings home that we need to really do something about how toxic our treatment is. And that's just looking at deaths from treatment. But actually, if you looked at the more subtle manifestations of treatment, these again results from the NOFO group who looked at randomizing 2 different types of asparaginase, one which they thought might be less toxic. The event-free survival was identical if you gave less asparaginase, but what they found was a significant reduction in the toxic events if you gave less asparaginase. So you had the same result in terms of event-free survival, but you had less toxicity. And although some of those toxicities are toxicities you can deal with, some of them can cause permanent disability for children. So things like osteonecrosis requiring joint replacement, diabetes after pancreatitis requiring permanent insulin therapy, etc. So actually another kind of take-home point from this is, if you were just looking at the event-free survival from this trial, you would say, well, there was no difference in the treatment arms, so we don't need to change our therapy. This overtreatment isn't obvious unless you look for it and actually look at all the cumulative toxicity within trials. And we know that our current way of capturing toxicity, of getting people to fill in adverse event forms and fax them off to the trials office, is very, very inefficient at capturing toxicities. So one of the things that we're hoping to do is pilot much more novel toxicity capture systems that allow you to capture real life toxicities in real time that are much more meaningful about what this means for the patients as they go through the treatment. And I'll come back to that right at the end. So one of the issues of the treatment-related mortality balancing the risk of relapse is that we're essentially potentially stuck between a bit of a rock and a hard place. So if we increase treatment intensity, we risk increasing treatment-related mortality, giving patients unnecessary toxicity and possible late effects. But if we decrease treatment intensity, we have a risk of increasing the relapse rate, having a lower overall survival, and we may end up actually having more children relapse who then end up getting cured when they have second-line treatment. But the second-line treatment generally involves stem cell transplant, and we know that's horrendously toxic to children. So you're swapping potentially a lot of children getting moderate in toxicity treatment for a few children who are going to get very, very toxic treatment. So you're again stuck between this kind of yin and yang, if you like. So one of the problems in this is that really what you want to be able to do is try and kind of tailor each child's treatment to their risk of relapse. But then you end up getting lots and lots of very tiny groups of patients. And so to actually prove that your modifications to therapy work, you need an awful lot of patients to show benefit. So that's the kind of background to where we are. So what we really want to do, and if you had a child with ALL and it was your child, what you would want is you'd say, okay, I realize, I'm worried about leukemia relapse, I'm worried about toxicity. What I want is my child to get exactly the right amount of leukemia therapy to cure their leukemia, but not too much because that'll give them toxicity, and not too little because that might cause them to get relapse. And at the same time, I'd like you to be able to try and minimize all those side effects, predict which side effects my child is at risk of, and try and prevent those side effects. And that basically comes down to what we call personalized medicine, so also known as precision medicine or stratified medicine or risk adapted therapy. But personalized medicine is essentially the ability to identify how sensitive each patient's disease will be to treatment, and also how sensitive the patient will be to treatment. So that's the toxicity side of it, not their disease, but their normal body tissues, and to use this information to adjust the therapy accordingly. So a lot of the way that, if you read about precision medicine and things in the press or in general kind of journals, they'll talk about kind of stratifying on the basis of DNA tests. But actually, it doesn't need to be DNA. It can be any way that you measure how sensitive the disease is to therapy and the patient is to therapy. And this is something we've been doing in ALL for a long time. So really, since the very first trials in ALL back in the 1960s, we have been risk stratifying our patients. So we've taken basic demographic features and realized that some things make patients more likely to relapse from leukemia than others. So we know that teenagers are more likely to relapse than younger children. We know that patients who have very high white cell counts in the peripheral blood when they present are more likely to relapse. We know that boys are more likely to relapse than girls. We know that T-cell ALL is more likely to relapse than than B-cell ALL. And we also know that certain cytogenetics are associated with either good risk leukemia or poor risk leukemia. And so right at the beginning, before kind of personalizing on anything fancy, we use age and white cell count to say whether you're going to get regimen A or regimen B, which is basically a 3-drug or a 4-drug induction. And then we add in cytogenetics when they're back, which usually takes a week or 2 to get back. And we upscale children with poor risk cytogenetics onto regimen C, which is more intensive again. And this does actually work. So if you end up on high risk regimen C because either you don't respond well to your first 4 weeks of therapy or you have these high risk cytogenetics, then your relapse risk is 50%. Whereas if you're not in regimen C, your relapse risk is only 20%. So you could say, well, we already can predict those children at risk of increased risk of relapse. But the problem is that only 10% of patients overall fit into the high risk regimen C. Whereas 90, and the issue here is about what we call the kind of denominator, if you like. So if you took a nominal 1,000 patients, then 100 would be high risk and 900 would be non-high risk, so 10%, 90%. And the relapse risk of these 100 is 50%, so 50 would relapse. And the relapse risk of these 900 is 20%, so 180 would relapse. So you can see, although the risk of relapse is much higher for regimen C, if you actually look at the number of children who relapse, most of the relapses are occurring in non-high risk children. So this is a really important concept that shows that it's difficult to use these general population characteristics to really personalize medicine. So you can kind of tell someone roughly what their relapse risk is, but you can't say what's gonna happen overall because you've got this percentages game, if you like. And that comes back to this idea that, just because you look bad doesn't mean you are bad. Just because you look good doesn't mean you are good. There's a lot of variety in that. And actually, you need something much more nuanced than just how old you are and what your white cell count is to decide what your risk of relapse is. And that's where we come to this concept of minimal residual disease. And I know Professor Gibson talked to you about MRD, but I think it is just such a key concept in ALL. It's worth kind of just going over it again so that people really understand why we're so fixated with MRD in ALL, if you like. So what MRD does is it produces a kind of global measure of response. So it measures all together how well your how much treatment you've received, so how intensive has the treatment been, how well have the treatments worked together, how much the treatments got into where the leukemia cells are living. How good were the patient kind of factors, like has your patient actually taken the treatment? Has it got into their bloodstream? Do they have host genetic determinants that mean they don't absorb a drug well or they metabolize it rapidly? And it also looks at your leukemia biology. So how much does your leukemia cell in your body get killed by the drugs that you've given it to? And how much is it rescued by the things like the niche it's sitting in and all these other kind of things? So it's a global measure of the response, because essentially it's measuring a child's individual leukemia cells in their body in response to therapy. So it's adding up all these different factors that will interplay to decide whether your leukemia cells are going to be killed by therapy. So in the olden days, we would take leukemia cells out of the body and test them with drugs in the test tube and then say, well, it's killed by this drug. But just because it's killed by a drug in a test tube doesn't mean it's going to be killed by a drug in the body, because in the body, the drug may not get into the body. It may get broken down in the body faster than you expect. It may be that the cells are rescued by stromal cells that give them the nutrients they're missing or detoxify the chemo, etc. So it's only by measuring it in the body that you can really get a good response for how well this child's leukemia is being killed by this treatment, if you like. And that's this idea of MRDs. So we do that in a very crude way by just seeing whether the leukemia cells go away when we look under the microscope. But leukemia by eye, you're only able to detect levels of disease of about 1%. So you can only really detect a leukemia cell compared to a normal cell when it gets to about 1 in 100 cells. When it gets down to 1 in 500 or 1 in 1,000 cells or 1 in 10,000 cells, your eye just isn't good enough at picking out those cells. But actually, this 1% level is not really that meaningful, because actually it's been estimated that when you're diagnosed with leukemia, you might have as many as 1 trillion leukemia cells in your body. So if you do a 2-log reduction in that from 100% down to 1%, that brings you down from 1 trillion cells to 1 billion cells. Now, most of us would say still having 1 billion cells of leukemia in your body doesn't mean that you're cured from leukemia. And it's these kind of children that are on the top part of this graph where they might go down below 1%, but they've still got these billion cells there. Those cells can quickly grow back up again and cause a relapse. Whereas there are other children where after a month of treatment, they've actually gone from 1 trillion cells down to 10 cells, say, and it's likely that those children are going to be highly sensitive to the chemo and they're going to be really cured. And then there's all these intermediates in between. So how deep your remission is, how many of these cells you get rid of, and how quickly you do it really determines what your risk of relapse is. So the kids that can go very, very shallow, they're likely to have early relapses. Ones that kind of go a bit deeper but don't really get down as far as you'd like are then just going to slowly grow back. Ones that kind of get below the level of detection but only just might grow back even slower. And then there are others that are going to be cured. So this is really, really important because it helps us identify which children are going to be cured and which ones need more intensive therapy. And it's been shown that MRD is really good at predicting relapse risk. So in contrast to my sums I showed you before, about 50% of children still have positive minimal residual disease children who have positive minimal residual disease at the end of therapy, which is about 45% of children, their relapse risk is 50%, which is the same as high-risk regimen C. But because that now, if we look at our fictional 1,000 patients again, that now captures 450 of our 1,000 patients, 225 of the relapses are in the MRD positive group, and only 5% of the relapses are in the MRD negative group. So we capture the vast majority of relapses with this technique. And as you can see, if you're MRD low risk here, your risk of relapse is really, really small. These are the intermediate risk, and these are the MRD high risk. And this was done in the German trial, but it's also been reiterated throughout kind of lots of treatment. So MRD is really, really good at predicting whether you're going to relapse or not. But actually, that's not really the question. If you're a parent, you don't really want to know whether your child's going to relapse or not, but whether there's anything you can do to prevent that. And so that's essentially what the UCAL 2003 trial did, was it compared, it asked 2 main questions, which I can't Oh yeah, I have got here. So the first thing is, if you've got that low risk MRD and you've got this really high cure rates, can you safely reduce treatment and still have the same cure rates but less toxicity? And then the second question is, if you've got high risk MRD, can you do something to change your fate, or are you just destined to have half of those children relapse? And so if you actually escalate treatment for the children with high risk MRD, will they be cured, more likely to be cured? And essentially, that's what 2003 show. I think Brendan went over this. So essentially, you can safely reduce treatment without having an increased risk of relapse for those at MRD low risk. And for those at MRD high risk, these are the figures. Those who got intensified treatment, only 18 of them relapsed, whereas those who got their original treatment, 31 relapsed. So essentially, you can halve the risk of relapse by intensifying the treatment. So this is the kind of that's the background to where we are now, and we've already discussed this. Although there are good outcomes, relapsed cancer is still the leading cause of death in child, and relapsed ALL has a poor prognosis. We've reached the limits of our conventional therapy because the risk of death from treatment-related toxicity is equal to the risk of relapse and death from disease. We've got really two main barriers to progress. One is that the very high-risk disease, which is very heterogeneous in terms of genetic subtypes. So each one of these high-risk diseases is a rare disease in itself, although collectively, obviously, it's a significant problem. And then we have cure at a considerable cost. And essentially, we've got to a point where scientific progress has been hampered by very small patient numbers in each different kind of cohort of people, children susceptible to each individual toxicity and each genetic subgroup. And it's very difficult for us to pool data across international boundaries and compare treatment outcomes because each country has different treatment backbones they use. They have different definitions of relapsed disease, refractory disease, and different definitions of toxicity. So that is where we get to all together. So this is halfway through my talk. I've eventually got to all together. So essentially, this was an initiative to try and deal with this issue. So we pretty much exhausted what we could do as individual countries with our different trials. So we decided to get together a consortium of countries across Western Europe, 14 different countries. That will involve more than 1,400 patients being recruited into our trials each year, which means we can split these patients up into small groups and still get scientific answers to our questions. So we can kind of personalize therapy, but within a large group of children. It's taking patients up to age, I think this is 1 to 29, I think it's 1 to 25 in the UK, up to age 45 across the consortium. And there's a couple of countries waiting to join. So essentially Spain and Cyprus are what we call observers at the moment. And once they have some of the techniques in place, they'll be able to join in principle. So what we want to do from all together is we obviously want to cure the remaining patients who die of ALL relapse, so by intensifying and using experimental therapy. We want to try and de-intensify treatment for patients who we think are overtreated. We want to try and, one of the ways we want to reduce toxicity for all children is to use targeted therapy for any patients that we think might benefit. So there's three main targeted therapies in this trial. There's use of tyrosine kinase inhibitors for patients with Abel class fusions. There's use of this drug called inotuzumab in first-line treatment for children with intermediate risk high disease. And there's stratification of patients to CAR T-cell therapy in the very high-risk group. And I'm going to come back to all three of those, so you don't need to remember them right now. And we also want to see if we can get even better at predicting which children are going to relapse to see which treatment they need by using innovative genetic stratification, which I will show you, and doing things like lots of drug monitoring for therapeutic levels of drugs, etc. So I've mentioned this, you have to have ALL, and you're not allowed to join in if you've got Philadelphia positive ALL, because that's treated on a different trial. You're not allowed to join if you've got lymphoblastic lymphoma, which is unlike the UCAL 2011 trial for those of you who work in the field. And you can't join if you've got c-Myc translocation positives. That basically means if you've got Burkitt's, which we also exclude from our current trials. So one of the things was all the trial groups we got together. So COAL is the German, DCOG is the Dutch, NOFO is the Nordic countries, and the UK, obviously, is that we've all got similar current event-free survival. So when we needed to decide on what protocol we were going to use, even though we all used different protocols, there wasn't one that was clearly superior. But unfortunately, they weren't identical either. So we had to have a kind of diplomatic kind of discussion about how we were going to amalgamate all these protocols into what we call a standard of care protocol that's going to be our backbone that we can compare our experimental observations against. So this was actually one of the main aims of this first altogether protocol, was to try and get an agreed protocol, an agreed way of reporting toxicity and agreed definitions, etc., agreed genetic stratification, which then allows us in the future to be much more imaginative about add-on studies we do for particular groups. But until we're all singing from the same hymn sheet, if you like, we can't really do any of that innovative science. So the first altogether protocol, although it has got some really exciting questions, is almost more about process and getting things working and everyone working together, if you like. So the important thing was to design a master protocol that then you could put kind of intervention modules into. So the master protocol was the standard of care, and then you would be able to ask questions within it. So it starts with a kind of diagnostic protocol, then a way of stratifying therapy, so using minimal residual disease, just like we do in UCAL 2011, and then risk stratified therapy into standard risk, intermediate risk low, intermediate risk high, and high risk. So it's very similar to UCAL 2011. The main difference is that this is regimen A, this is regimen C, and all that's happened here is we've kind of split regimen B, if you like, into two different categories, and I'll show you why that is in a minute. And then within that master protocol, we then have the randomizations. So the idea is that these two lower risk groups will be randomized to de-intensifying therapy if you're less than 16 years old. The high-risk groups will be randomized to getting some new drugs so that we can try and intensify them without causing more toxicity. So for the IR high group, it's inotuzumab, and for the ABL class fusions, it's TKI, and for the very high-risk patients who've got B-cell precursor ALL, it's CAR-T. And this is really innovative, if you like. Up till now, we've really only used immunotherapies for relapsed disease. So we've used blinatumomab, inotuzumab, and CAR T-cell for patients with relapsed and disease. And this is bringing these immunotherapies into our upfront protocol, which is something that we've really wanted to do because we think that these immunotherapies are less toxic long-term to the body. And they have some short-term toxicities, but they don't cause damage to normal cells because they're more targeted just to getting leukemia cells and not normal cells. And so if we can bring these into upfront therapy, hopefully we can cure these children without really big problems with long-term toxicity from therapy. So it is really exciting altogether, the ability to be able to offer these things to patients with newly diagnosed leukemia, admittedly to just the high-risk ones at the moment. Not all of these modules, these different randomizations will report all at the same time. So it's a kind of going to be a rolling trial, if you like. Once you've answered one question, you'll then maybe add in a different study for that group of patients, but carry on potentially with the randomizations and the study for the other groups as we go along. And there may well be modules added later on. So there will be amendments, as there are with all trials. And we'll come back to this, but the CAR T-cell therapy is being offered to the altogether patients, but it's not actually officially on the altogether protocol. So if you're randomized or allocated a CAR T-cell therapy, you will go off protocol and onto a separate CAR T-cell study. And that's really to do with regulatory reasons and lots of things around the governance of CAR T-cell therapy. So technical things mean it can't really be part of altogether, but the altogether patients get funneled into the CAR T-cell trials. Okay, so this therapy overview is why Altogether has got a bad name amongst research nurses, PIs, junior doctors, etc., because it just looks really, really complicated. But actually, it's really not that complicated, and it's not that unfamiliar if you are familiar with the UCAL 2011 protocol. So actually, UK is one of the biggest contributors to the trial with very good results. Actually had a lot of say in the backbone therapy, and you will recognise the standard of care, an awful lot of it, from UCAL 2003 and UCAL 2011. So the backbone, the kind of structure is the same. We have induction, consolidation, interim maintenance, then a delayed intensification. Then there's a second interim maintenance, and then a maintenance. So it's very familiar to us who work on UCAL 2011. And actually, the induction looks pretty much identical to UCAL 2011. So it's NCI risk stratified 3 or 4 drug induction. Apologies if you're not working in the leukemia field and this is just like gobbledygook to you, but this is just useful for us who are working on ALL wards to just understand that this is essentially the same as UCAL 2011. The consolidation is a BFM consolidation. With 2 lots of PEG asparaginase, and the interim maintenance is currently high-dose methotrexate, although when the results of UCAL 2011 play out and we have a result about whether high-dose methotrexate is superior or not, this could change. And then the DI does look a little bit different, especially for the intermediate risk high group, but is still the same kind of idea of an intensive combination of drugs delivered over a few weeks. And then if you're in an intermediate risk, you have a couple more high-dose methotrexates before going on to maintenance. And maintenance, one of the differences between this and UCAL 2003 is that maintenance is 2 years for both boys and girls, whereas previously it was 3 years for boys and 2 years for girls. And we're dropping pulses in standard risk patients, and we're randomizing them as we do for UCAL 2011 for the intermediate risk patients. So just to kind of take a few of those things in order. The risk stratification, again, I think Brenda touched on this, but this is essentially a histogram of your risk of relapse along the y-axis compared to your relative risk of your MRD level along the x-axis. So you can see when you get up to MRD levels greater than 5%, your relapse risk kind of goes up to 30%. Whereas if you've got relapse, if you've got MRD less than 0.01%, then your risk of relapse is between 5% and 1%, so very, very low. This is when you look at all patients with ALL over as a whole. But if you do look at the different cytogenetic risk groups and see what their MRD profile looks like, you can see that if you've got good risk cytogenetics, this is the 1221 translocation, even if you have quite high levels of MRD, like nearly 5% here, you still have really low levels of relapse. Whereas if you've got cytogenetic high risk ALL, then even at this 0.01% level, you actually still have a 20% risk of relapse. So you can see that actually, in order to try and get an MRD to a level where you can predict low relapse, you need to change this dashed line depending on what your cytogenetics are. So for TEL-AML1, you can actually move it to the right. You could actually have a higher level of MRD and still be at very low risk of relapse. Whereas you can see for the cytogenetic high risk, you actually need to make it to the left and make it an even lower level of MRD if you want to really pick out the good players. And that's essentially all that MRD, the tailored MRD levels for Altogether are doing. So now you don't have one MRD level of 0.01%, which means you're high risk or low risk. It's different MRD levels for each of these different groups. But that's going to be reported back and interpreted by the lab for you. So you're still going to have children who are high risk or low risk. It's just the exact level of MRD that determines whether you're high or low risk will have shifted. And then there's a second genetic risk factor that's come in, so more sophisticated genetic identification of patients has allowed us to develop new tests. So this thing called a copy number alteration classifier. You don't need to know this in detail, but just to say, again, this can be used to say whether you're high risk, intermediate or low risk. So this is going to be integrated with the MRD results so that the lab will come back and saying, on average, your patient is in a good, or standard, intermediate or high risk group. And then if we look at the standard risk, so this is the good, what we would have normally have been regimen A patients. What are we doing for these patients? So these are the ones at lowest risk of relapse. So what we want to do for them is try and reduce their toxicity further from our treatment. So the idea is to try and remove anthracyclines, so doxorubicin, from their therapy altogether, because we know that doxorubicin is associated with long-term cardiac damage, so a lot of cardiotoxicity, and also is thought to be related to an increased risk of infectious complications. And infection is actually the leading cause of treatment-related mortality in ALL. So these are children that we expect to kind of have a 95% cure rate, so we don't want to expose them to a drug that might kill them due to infections during treatment. So the randomization here is with or without doxorubicin in your delayed intensification block, and about 25% of patients will fit in this standard risk group. Then the intermediate risk group is the one there is a bit of a difference between UCAL 2011 because it's been split into two. So these are the patients who have some detectable MRD, but it's got to be less than 5%. And then they're further split into what we call IR low and IR high on the basis of this really complex genetic classification that you really don't need to worry about too much, apart from to be told whether your patient is an IR low or IR high. And the reason that they're split into this is if you look at children who fall in these complex groups, those who fall into IR low have a relapse risk of 4% and an event-free survival of 94%. So they're really pretty similar to the standard risk, the regimen A patients. Whereas those that fit in IR high have a relapse risk of 15% and an event-free survival of 82%. So you can see that they're not a homogeneous group here. And actually, if you take these children who have these MRD levels here, about half and half will fit into each of these groups. So it's well worth knowing whether your combination of MRD and genetic abnormalities mean that you're IR low or IR high, because you're looking at a very different outcome. And the questions you want to ask in these two groups are really quite different. So in our IR low patients, we again are going for de-escalation. So we also want to remove doxorubicin, and we also want to see if we can remove pulses from their maintenance. So that's the Vinc and Dex pulses. And one of the reasons we really want to do that is we know that Vinc or Dex in particular is associated with really quite significant side effects in children, with a lot of problems with mood and eating, and a lot of and potentially in older children problems with osteonecrosis, etc. So it's a really quite a toxic drug. So in this IR low risk group, we're testing removing dox and removing pulses. So this is very similar to 2011, really, the kind of things we were doing there with the 4-way randomization. The other thing I think I mentioned before was this novel toxicity capture system. So that allows us to really report on key toxicities in real time rather than having to do SAE reporting. And this should allow us to really identify whether removing dox and reducing pulses is less toxic. Okay, so in the last 10 minutes, I just want to talk about some of the novel therapy in UCAL 2011 and really going beyond our traditional treatments of these alkylating agents and vincristine, etc. So one of the real success stories in terms of novel targeted treatments is the use of tyrosine kinase inhibitors in Philadelphia positive ALL. So it used to be that Philadelphia positive ALL had a really poor outcome, 20% event-free survival, and all these patients needed bone marrow transplant. Whereas having introduced imatinib or dasatinib as a tyrosine kinase inhibitor, which inhibits the BCR-ABL, which drives this disease, you can see that our results with just chemotherapy only, without even a bone marrow transplant, are really, really good now. And so children with Philadelphia positive ALL get transferred off altogether to go on to the Philadelphia positive ALL protocol SFAL, where they get imatinib. But there was also this group that was identified as essentially having the same genetic profile as Philadelphia positive ALL, so what was called BCR-ABL like ALL. So when you do gene expression profiling, they cluster all together. They look exactly like Philadelphia positive ALL, except they haven't got the Philadelphia chromosome. So when you go and look for it, you don't have a 922 translocation, but on gene expression, they look just like they've got the Philadelphia chromosome. And if you look at these children, they similarly do really quite badly. So the red line here is the BCR-ABL like, and the grey line is the BCR-ABL positive. So they do really badly in terms of disease-free survival, and genetically they look really the same, but they don't have the Philadelphia chromosome. And what's going on in these children is that they've got alternative translocations that end up fusing and activating kinases, which means that they are also susceptible to kinase inhibitors, tyrosine kinase inhibitors. So you can see these children who have these what we call ABL class fusions and JAK-STAT fusions, etc., have a really high rate of relapse. And so one of the things that's happening on altogether is that these children who have these ABL class fusions, which we can detect genetically, are going to get a TKI. So they're going to stay on trial. The Philadelphia positive ones are going off to SFAL. The SFAL doesn't include patients without the Philadelphia chromosome. So the rest of them are going to stay on trial, but they're going to get TKI added into their backbone therapy to see whether that can improve their outcome. And then the other thing that I alluded to was the inclusion of immunotherapy. So immunotherapy is using the patient's own immune system to kill cancer cells. It's a really promising new treatment for childhood cancers, particularly hematological malignancies. There's many, many different forms, but the commonest two used in leukemia treatment are what are called BiTEs, so bispecific T-cell engaging antibodies, which are antibody fragments that bind on one side to a B cell, which is the leukemia cell, and the other side to a normal T cell, and brings the T cell right next to the leukemia cell so that it can kill the leukemia cell easily. You wouldn't think that would work, but it does. So essentially, you can persuade a T cell to kill a leukemia cell just by bringing it close enough to the leukemia cell. So this is things like blinatumomab. And then the other thing is these immunotoxins. So they're antibodies that carry a kind of payload, like a bomb, that when they get internalized, then the bomb goes off inside the cell. And we'll come back to that in a second. So we're using inotuzumab in altogether. And then the third really popular one is CAR T-cell therapy, which I'll come on to at the end. So this is inotuzumab. So inotuzumab is an anti-CD22 antibody. So CD22 is expressed on the majority of BALLs. The antibody binds to CD22. It gets internalized, and on the end of the antibody, it's carrying this potent antibiotic called calicheamycin, which integrates into the cell, intercalates into DNA, and causes apoptosis. And this is actually the same drug that's used in Mylotarg, which we're familiar of using in AML therapy, but the antibody that's conjugated to is different. So in AML, it's anti-CD33, and here it's anti-CD22. Almost all our BCP ALLs express CD22, and it seems to be really, really effective in relapsed and refractory ALL. So we want to try and bring it up frontline to see whether we can use it in frontline therapies. And then, so why am I showing you this? So this is the intermediate risk high. So these children are getting their standard therapy, which looks reasonably similar to our regimen B therapy at the moment. But then they get randomized between just getting their maintenance or getting this novel agent inotuzumab. So they get a 50-50 chance of getting inotuzumab. And this is this idea of potentially what we call a pick a winner. This is an investigational window. So if inotuzumab works, that would become the standard arm, and then we would be able to slot in potentially a different novel agent here if we thought we could improve on things. Or if inotuzumab doesn't work, we can slot in another different agent here for these IR high patients along the line. So you don't necessarily have to change the whole trial. You can just keep slotting different things in and out of it, depending on whether they look like they work. It's what's called kind of winner stays on or pick a winner kind of thing. And then just the very last two slides I think I wanted to say was on the very high risk patients. So this is the idea that the very high risk patients will, if they're B cell patients, will be able to benefit from getting a CAR T cell therapy up front without having to wait for them to relapse. So we know these high risk patients do really, really badly. So if you have an MRD at the end of consolidation of greater than 0.01%, your disease-free survival is only 20%. So 80% of these kids are going to relapse. So that's what justifies giving them the CAR T cell up front rather than before they relapse. Doing CAR T cells is whole talk in itself, but the idea of CAR T cells essentially is that you take a T cell receptor, which is normally MHC restricted and can cause graft-versus-host disease, etc., but you replace the extracellular portion with essentially an antibody-based linker that you can make against CD19 or CD22 or any other antigen you want. And that's got massive advantages over just expanding T cells, because you can make it recognize any antigen you like. It doesn't, it's not MHC restricted, and then you can join it inside the cell to the normal stimulating mechanism in the CAR T cells. So you take the patient's T cells out, you then add in this antibody construct, and then you add them back into the patients, and then they will go and find any cell that's expressing this antigen and basically use T cells to kill. They'll proliferate, they'll kill those cells and make more copies of themselves so they can mop up any residual leukemia. So CAR T cell is part of the high risk arm. Obviously, if you've got T cell ALL, it's really hard to make T cells kill other T cells, so they will have to go along the more standard blocks of intensive therapy and to stem cell transplant. But this high risk arm, although it is complex and it involves transplant and CAR T cell, etc., it's actually only 3% of the patients. So there's going to be very few patients coming through this arm. So 75% of the patients fit in this intermediate risk, and 22% in this standard risk arm. So we're really talking about very small numbers of patients in the trial. And I just wanted to end by saying that I said at the beginning that Altogether was really a backbone that allowed us to do lots of other studies because we had much larger numbers of patients. And so the idea is that there's going to be really quite a big research kind of profile of add-on studies, a lot done with biobank samples from the trial at particular subgroups to see if we can identify novel treatments and problems to do with predictors of toxicity. And there is already quite a few studies that look at ways to try and minimize the side effects of treatment. So we are running here in Glasgow the BRAIN study with some No.7 colleagues, which is using biomarkers to reform approaches to therapy-induced neurotoxicity and using Cogstate and collecting CSFs. We also have a CSF flow study that we're also running from here in Glasgow, which will try and adapt CNS-directed therapy according to your risk of CNS relapse. We've got a patient-reported outcomes measure study. We've got an asparaginase study. We've got what's called GPS, which is a genotype-phenotype study that allows you to look at the patients who get toxicity in their genes and see why they're particularly prone to getting toxicity. We've got potentially opening 2 other supportive care studies looking at using ciprofloxacin to prevent bacterial infections and using apixaban in older children to prevent thrombosis. So there is going to be a lot of kind of accompanying science done with this study, as well as asking these kind of clinical questions. So that's an awful lot of information in a short amount of time. It's a good thing it's recorded, so you can kind of go back and peruse it. But I hope that's given you a flavour of the kind of things that we're doing. I'm very happy to answer any questions as needed. I'm going to try and stop sharing my screen if that works. It may take a wee while. So,
Christina, thank you so much.
Pleasure. So open to any questions if anyone would like.
No, does anybody have any questions?
No, I don't think so here in Glasgow, no.
Okay.